So what we're going to do this morning, we have a couple of objectives, 4 and 5, that really talk about the diagnostic test and the procedures. So I want to kind of make this a little bit conversational, but also go over some key points, because I feel like these objectives are a little bit broad and they cover a lot of stuff. So as I was looking through your book, I jotted down a few tests. So I kind of broke them up into categories. For example, this right here is cultures. Cultures, radiology, blood test, and then also different types of invasive procedures. Okay? So I want to go over these, and then we can ask some questions about them and see where we are. This follows objective 4, where it says identify the purposes of various diagnostic tests commonly performed to evaluate a patient's health, and procedural steps, as well as evaluating patient health. And something that number 6, patient teaching also. So this is all encompassed in those 3 objectives, and the big things are going to be focused on patient teaching and also the procedures, because in fundamentals, we're not talking about the disease process per se. We do these tests for a diagnostic reason, but we're talking about the procedure to keep you safe and to keep the patient safe, as well as to accomplish a goal. Come on in. You can come on in. Yeah. Okay. So the diagnostic tests that are cultures. The first one I want to talk about is a blood culture. Why do we do a blood culture? We do a blood culture to determine if there is a bacteria, a parasite, some type of an infection that's in the blood. 2 things I really want you to know about blood cultures. When they do blood cultures, they have to take it from 2 separate sites. So they may draw blood from an arm and take blood from an IV, right? And then it takes about 24 to 48 hours for those cultures to grow. Cultures are not going to give you immediate results. And the reason we're doing it is to find out what is making the person sick. The next type of culture is a urine culture. So whether we're collecting urine for a culture, whether we're collecting urine for just a urinalysis, which is a UA, or whether we're collecting urine in a midstream, I put CVS in there because you may see that term. CVS stands for clean voided specimen. It's the same thing as a midstream urine. In your lecture, Ms. Brooks talks about collecting the urine midstream. The reason we do that is because we want to get sterile urine. Come over here. Yes.
So all 3, the blood, urine, and wound, all take 12 to 24 hours?
Typically, it's at least 24 hours to get a culture, for it to grow. So a lot of times if you go to the doctor's office and you need a culture, they'll go ahead, and they think that you have an infection, they'll go ahead and start you on antibiotics until the culture grows something. Then once the culture grows something and they know, okay, this is the antibiotic that's going to treat this, we're going to continue this course. Or if it grows something that the antibiotic is not sensitive to, then that's when they'll change your medicine. You know what I'm saying? You probably have had this done or know somebody who's had this done before, but that's why they call it a culture and sensitivity, right? Because after the culture grows, then we have to determine which antibiotic is sensitive to that organism or that infectious material, okay? So in here, in the urine, we can do a UA, which all we do is have you pee in a cup. However, we want a urine culture, it has to be sterile. So you have to make sure that you teach the patient to clean the labia. And the proper method, it's listed in your book, is to use 3 wipes to clean 3 times. And then when you start peeing, you catch the urine in a sterile cup. Now, does that mean it's a sterile procedure? No, it's not a sterile procedure, but we want to use sterile equipment, so we use the sterile cup. Then the 12 to 24 hour, let me tell you about that. If the doctor orders a 12-hour or a 24-hour urine, you wait until the patient urinates. So he orders it at 8 a.m. You go in, what are you going to do? Go in and say, I need you to pee? Well, what if I can't? So as soon as they pee, you throw that first one away. And you mark the time. So they peed at 10 o'clock. 10 o'clock is when it starts. You throw that away. Okay? Then you collect that urine for as long as they want you to collect it, up to 12 or 24 hours. The thing with that is the urine has to be kept in a jug, either on ice, or what if they have a catheter? What if they have a catheter, and then what do we do?
Get it from the Foley bag.
We would, if they ordered a 12 or a 24-hour urine and they have a Foley catheter, then you would start it whenever you empty the catheter, right? You would empty it, start from scratch, start with nothing, collect it, and again, you would have to keep like a bath basin or a bucket of ice and keep the catheter on ice while you're collecting it, because it has to be kept cold. Okay? So 24 hours, just remember that you throw away the first one, start it at the time you threw it away, and then collect the urine for 24 hours. Now it talks about the nursing process. When you're collecting cultures, any kind of culture, you have to make sure you document the time, the patient's name, and who collected it. So say you're getting a blood culture or you're getting a urine culture. On that culture, you're going to document obviously you're going to have in the hospital, you would have a sticker with the patient's information, right? But on that sticker, you're going to document your name, you're going to document the time, and obviously you have the patient information on there too. Okay?
Excuse me, Ms. Brown, are they coming to get us, the ones that have to do the lab checkoff, or should we just go ahead and leave this, they say 10 o'clock?
They'll come get you,
Okay.
I think.
Okay.
I guess we should have communicated with each other. Okay, so, yeah.
You said the name, the date, your initials, what else?
And your patient information. Make sure that you label it with your patient information as well. Like I said, in the hospital, you may have a sticker, but you may not in long-term care. You may have to write out the patient information. Just make sure you have the patient information labeled on there as well. Okay. Wound cultures, when you collect a wound culture, it's the same thing. It's not a sterile procedure per se, but you have to make sure that you collect it in the sterile equipment. Okay? You're going to make sure that you have, typically with a wound culture, there's a tube, and you submit the culture material into what they call a medium or a contrast medium. So it's kind of just like a liquid. You just have to make sure you're not touching the sides. Not touching the sides of the container. Also important when you are teaching somebody how to collect their own urine. You don't want to hold the cup and touch the skin of your vagina, okay, or your penis. You want to try to hold it a little bit away and just try to catch it that way. So either way, no matter what the container is, you just want to try to keep from touching the sides. Wound cultures, again, are going to take, 24 to 48 hours to actually get a full result. So what they'll do is if they think there's an infection, they'll start the patient on some type of antibiotic therapy and hope that that's the one that will treat it. And if not, that's when they change the antibiotics, when the doctor comes in and says, oh, this is what the wound was growing. It's going to need a different medicine. Okay? So that's what I wanted to talk about as far as cultures go. Let's talk about some radiology things. And with radiology, the number one role for nurses is patient teaching. You have to teach them what to expect because some people don't understand. Okay, when you go in for a regular x-ray, what they're doing is they're just looking. They can visualize certain things, tissues and bones on an x-ray. But if they're looking for some type of a tumor or something, they'll do a CAT scan. A CAT scan is still a pretty fast test. You just go in, and they're basically, again, looking for any abnormalities. They're looking for, injuries, tumors, just things that are abnormal in the body. But when they do an MRI, that's where your patient teaching becomes more focused because that's a longer test. MRIs sometimes can last up to 2 to 4 hours, sometimes 6 hours. It just depends what they're all scanning. If they're doing a spine, it's typically about an hour. If they're doing a brain, sometimes it's 2 hours. So the big thing is with MRIs, if you haven't had one before, is that people who are claustrophobic may have problems with them. I need to pause. Yes.
Anybody in here for checkups? Yes. For Ann and Maya.
You guys can come back, and I'm recording this, so just hang in there. Okay, so with an MRI, there's several things because it is magnetic. It stands for magnetic resonance imaging. Because it's magnetic, you need to make sure that your patient is free from any metal. So a patient who has metal implants, like maybe a pacemaker or some type of other metal device, might not be able to have an MRI. A patient back in the day, I know they've done tattoos a little differently now with non-metal ink, but back in the day, if somebody had a tattoo and there was metal in the ink, they couldn't have an MRI for a year because if, say they got a tattoo on their neck or in the back of their head, that metal could go to your eye. That magnet would go and make you go blind. Okay, so I know that's why they, one of the things that they did is they started making tattoos that don't have the metal in the ink anymore. So if you have a pacemaker, that's got metal in it. Probably can't have an MRI at that time. The other thing about MRIs would be teaching your patient. Sometimes we have to give them a little bit of a sedative if they're claustrophobic and they're frightened of being in the tube because it's very loud. So you're going to teach them that it's very loud, and they will put in headphones over their ears to kind of muffle the sound, and maybe they might want to wear an extra pair of earplugs.
So can they go to sleep while they're in there?
They can go to sleep.
Yeah, that's what I would have to do.
Yeah, I definitely like to be
Just let me go.
They can go to sleep, but it's very loud, and you're in there for sometimes several hours. Okay? So, again, part of the nurse's role is going to be calming the anxiety of someone who may be claustrophobic and has to have an MRI. The next type of a scan is a PET scan. And I can't remember off the top of my head what PET stands for, but it encompasses the whole body. It is the longest of the scans. And the PET scan is is the one that they typically will do when there is some type of a metastasis growing. So you probably you not only had cancer in your lungs, but now they're thinking it traveled to the liver, it traveled to the brain, it might be in the bones. Maybe it's not cancer, maybe it's something else where they have to do a PET scan, but for the most common reason, it's probably to see if a tumor has metastasized and it's growing and whether or not they can treat it. And that's why they would do a PET scan. So again, the x-ray is the least invasive. Always important for any of these scans to ask your patient what, especially if she's a female. Ask about pregnancy. Okay, so that's another reason that you may not be able to have a radioactive test, is if you're pregnant. They might postpone it for a later time. Okay. Over here, we talk about some different blood tests. So when we say blood test, what we're talking about, the word is venipuncture, because they're going into a vein to get the blood. And when you have IV therapy, you're going to practice that in the lab. You're going to practice putting in IVs as well as venipuncture. So there's a couple of tests that are in your book that specifically we need to talk about right now. And the first one is a CBC, or a complete blood count is what they call it. And that's the test that they'll draw to see if there is an infection, especially if somebody has a fever and we don't know why they have a fever. They have no other symptoms but just a fever. Okay? We have to see what's going on. Typically, in a complete blood count, they're measuring all different kinds of things. They're measuring the red blood cells. They're measuring the white blood cells. They're measuring the hemoglobin and the hematocrit. They're measuring neutrophils and different things like that that are going to demonstrate whether or not the patient's blood levels represent infection. Not only infection, but a CBC is also used to determine different types of blood disorders, like anemia, like different anemias. There's many different kinds of anemias. And a lot of other things, clotting factors and things like that. Really, as far as patient teaching for any of these blood tests, you're mainly just letting them know that it is going to be something that they may have to repeat. For example, if they get their blood test and something's abnormal, would we want to repeat it in maybe a week or 2 weeks? Yeah.
Yes.
So H&H is in that CBC, and H&H stands for hemoglobin and hematocrit. Okay, at this point in the program, it looks like they're not having you learn the normals. I'm not going to focus on the normals. I just want to focus on what is hemoglobin and what is hematocrit. What's the difference? And this is something that's kind of difficult, I think, because they're both related to oxygen. However, hemoglobin is the ability for the body to carry the oxygenated blood. So hypothetically, if a normal hemoglobin is 9 to 11, and you draw their blood and their hemoglobin is 8, what would you think their skin would look like? Pale. Okay? Oxygenated skin is pink, it blanches, and it's healthy. Okay? So that's where, again, it's another way to diagnose certain types of diseases. The difference between hemoglobin and hematocrit is the number of oxygenated red blood cells. So they go together because if your hemoglobin, if you don't have the ability to carry oxygenated blood, the number is going to decrease, right? So, let me just tell you. Where's my marker? Typically, let's use the number 10 because that's easy, okay? If a normal hemoglobin is 9 to 12, remember everything in nursing is a range, okay? And the way you can remember hemoglobin and hematocrit is it's a 1 to 3 ratio. And what I mean is if my hemoglobin is 10, my hematocrit is 30. That's what I mean by 1 to 3 ratio. Because they go together. Because the hemoglobin is the body's ability to carry the oxygenated blood, right? And the hematocrit is the number or the amount of those oxygenated red blood cells. So if my hemoglobin is 9, and I multiply that times 3, what do I get? My hematocrit you would expect your hematocrit to be around 27 because it's a 1 to 3 ratio basically. See? When you're looking at lab values, you will notice that they go together, and that's why when you have them in a blood test that they are measured like that. The next test is the chemistry panel. They call it a chemistry because it's all of your electrolytes that are on the periodic table in a chemistry class. Your sodium, your potassium, your magnesium, your calcium, your phosphorus, and so forth. Okay, in our program, there are 3 electrolytes that you really have to focus on. And that you don't have to write this down for this course, but I'm just telling you it's going to be sodium and potassium and calcium. Those are the 3 that you really have to focus on. So what we're doing here is we're checking to see if the sodium, the potassium, and the calcium are within normal limits. Because when they're not, disease happens, illness happens. When my calcium is off, when my potassium is off, I have heart problems, I have bone problems, I have muscle problems. Okay? I have kidney problems. I have all kinds of problems when those electrolytes are off. So that's what they're looking at. The next one is the prothrombin time and the INR. Those also go together just like an H&H goes together. The PT stands for prothrombin. Prothrombin time. That means the time it takes the blood to clot. The INR is the most important thing that we look at because the INR stands for the international ratio. What that means, if you have your blood tested at LabCorp down the street, and then you go to France and you have your blood tested at a LabCorp over there, if the INR is the same, then we know that the test is the same, that it's correct. So it's very important to look at the INR to see how fast your blood is clotting, because if the INR is too high, what does that mean? What do you think? Okay, if I just told you that this is the time it takes the blood to clot, okay? The time it takes. So if they look at the PT and INR when they're giving anticoagulants like heparin and Coumadin. And if they like the INR to be around 1 to 1.5, something like that. But if my INR is 2 to 3, what does that mean?
Blood clots.
It's taking longer
Right.
for the blood to clot. So the blood would be thinner. Okay, right. So right, for lack of a better word, we're going to say thinner. Okay, because what this means, if this is 1 to 2 seconds, it's in seconds, by the way. Okay, not minutes, it's in seconds. So if the INR is 1 to 2 seconds, and I'm giving an anticoagulant like heparin, a medicine, and that increases it from 2 to 3 seconds, okay, it puts me at risk for hemorrhaging. See? But if my INR is too low, I'm at risk for blood clots. So some people, like, I'll use Miss Espinoza as an example. She got into a car accident. You guys heard that, right? So, you know, she's on a lot of medication now because she had to have surgery. So, you know, she is at risk for blood clots already, and now she got into a car accident and she's on all these anticoagulants. What does that mean? She could also have an injury and hemorrhage. We got to be very careful. If we didn't watch the INR and the PT on patients like that, then we could cause harm by giving them too much anticoagulant therapy. Okay. Another blood test is the ESR, or the estimated sedimentation rate.
Which one?
Yeah.
I'm sorry, I got that PT is the prothrombin time, so how long it takes to clot. What was the definition for INR?
The INR is the international ratio, and that's more what they look at because it's the time in seconds. Okay, and you don't have to know the normals just yet. Don't worry about learning the normals. Just know what they're for. Okay, because we're going to build on this when you get into second and third trimester as far as knowing what the values mean. Okay, the ESR is the sed rate, sedimentation rate, and that's a test that we use to determine inflammatory responses. How does this test work? So they take a tube of blood. Have you ever seen them take a tube of blood and put it in a spinner and spin it down? Okay? That's what this test is. They spin it down, and it's how fast does it take the blood to separate, for all the clots to fall to the bottom. The faster, so the higher the sed rate, means that the body is having some type of an inflammatory response. So basically, that's a test that we would use for autoimmune diseases. Possibly maybe AIDS, maybe rheumatoid arthritis, because that's very inflammatory, maybe lupus. So autoimmune diseases that we really don't have a cure for, they may need to monitor that sedimentation rate to see if we're keeping that within a normal level. Okay. Then the next is just the blood glucose test. We do that for diabetic patients, but not only diabetic patients, patients that we're treating that maybe are in the hospital that for a long period of time who suddenly have become sedentary, and maybe we're giving them IV fluids that have sugar in it. So we will monitor blood glucose levels on all kinds of patients, but primarily diabetics, whether they're on insulin or even if they're taking oral anti-diabetics or anti-hypoglycemic drugs. Did you guys go over any oral hypoglycemic drugs or insulin? No?
Like
Metformin is a common, good answer. Metformin is a common one. Glipizide is another, but yeah, I was just checking to see if, if they're on insulin. You haven't done insulin yet either, have you? Okay. So just know that you would monitor the blood glucose levels for anybody who is being treated with diabetes medication or possibly a new change to a sedentary lifestyle and getting IV fluids. Okay. The other test that we have over here, I want to talk a lot about the nursing process as well as teaching. And these are different scopes. Let's talk about the scopes first. In your book, it talks about an endoscopy, a bronchoscopy, a colonoscopy, a sigmoidoscopy, all of that. Early on in PVC, we talked about scoping means going in and looking. Where are we going in to look? Okay. When we do an endoscope or a bronchoscope, either one, we're going in through the throat, right? We're anesthetizing the throat. We're going in to look at the lungs, or we're going in to look at the GI tract, the stomach, right? So, what do you think you would teach your patient if they had to be put to sleep or anesthetized of the throat for something like this? Nothing by mouth? NPO? Maybe for 12 hours or 24 hours, depending upon what the doctor wants them to do. So if they have to be NPO for a while, and then pain medication-wise, afterwards, they may need some mild pain medication. What about if they come out of the procedure and they're thirsty? What are you going to look for before you give them a drink? Okay, you're saying abrasions or if their throat is dry. I'm thinking more safety. We just anesthetize your throat. Make sure what? Make sure they can swallow. Make sure they can cough. You said that their throat was scratchy, so that's, make sure they can cough. They have a gag reflex, and make sure they can swallow. So that's one of the big things with any type of scope that they're going to go down the throat. Now, what if they're going up the rectum, like a colonoscope or a sigmoidoscopy? Is there any special patient teaching that you would think that you would need to inform them of prior to this test? Well, no, you can have stuff by mouth, but they want to clean out your bowels. They want to completely clean out your bowels. A lot of times, it just depends on the doctors, but a lot of times they'll just have you drink clear liquids for 24 hours, sometimes even longer than that. There's a medication called Miralax Golightly, right? That sometimes they'll have patients take laxatives as well, which is also, they mix it into a clear liquid. But they have to clean you out before you can have this test. And a lot of times that's the nurse's responsibility to teach the patient. Make sure that you have done that. Started at this time of the day so you can prepare. And then you stop, again, nothing by mouth, after a certain time, right? Maybe that's 8 hours, maybe it's 12 hours, but again, nothing by mouth. It just depends. I will tell you that I worked in a medical surgical unit, and out of 4 different GI doctors, they all had different preps. But the one thing that's consistent is that you have to clean out your bowels with clear liquids, and you have to be NPO so that they can sedate you. Okay. What about post-op? Post-operatively for a colonoscopy, would you think there's any patient teaching?
Maybe like to, you said after a colonoscopy?
Mm-hmm.
Like,
Like maybe to look for abnormalities in the stool?
Yeah, maybe just hopefully monitor for blood. There shouldn't be, but if it was normal, there shouldn't be. But if they found something and they had to take a what they call a biopsy, then they might have a little bit of bleeding. Okay. Thoracentesis, that's where they go into the pleural cavity in the chest. There's a picture in your book that shows how you're going to teach the client to sit. Primarily, they will have the client sit with their arms on a table in that position. So make sure you know that they're going with a needle, and what are they doing? They're taking fluid off of the
Lungs.
thoracic cavity, yes. So they're going to go right into that pleural space, right in there. See that?
Okay,
So-
429.
Somebody who has an injury and may have a fluid accumulation around the chest wall is going to need this procedure to help them breathe. So that's when they're doing that part. The next test is a cardiac cath. So somebody who presents with symptoms of chest pain, or somebody who's having a cardiac history that requires this, they'll do a cardiac cath. The most common place to go in for a cardiac cath is the femoral artery. So they go in the groin. I'm not saying that they don't do it other places, because now they do it other places. If you work in a cath lab or whatnot, you've probably seen them even go in through the wrist or through the elbow or what have you. But for the most part, traditionally, they'll go in through the femoral artery and look around to, again, diagnose any different anomalies, look at the valves, see if there's anything they can do to help this patient with their symptoms of cardiac problems. So pre-op, you would be NPO, right? What about post? What are we going to teach them post-operatively? They have to lay flat for typically 6 to 8 hours. Very good. And we're going into that femoral artery with a pretty big catheter. So they have to lay flat, and they have to have a pressure dressing on there. Back in the day, they used to call it a sandbag, but I believe they've changed the wording, and it's like 2 to 5 pounds of pressure that you want to keep on that femoral area. As a nurse, because we're going into that femoral vein, what are we going to assess on the legs?
Circulation.
We're going to assess circulation. So we're going to look for the color of the skin. We're going to look for the pedal pulses. Can they move their toes? Can they wiggle their feet? We're going to make sure that everything on the left side is the same on the right side. Okay? And make sure that they lay flat long enough with a pressure dressing so that it allows that puncture site to heal. Prior to a cardiac cath, they're probably going to do what your book calls an ECG, which is an electrocardiogram, is also called an EKG, so don't get those two acronyms mixed up. They're the same thing. They have a cardiac rhythm in your book. It's normal sinus rhythm, but that, again, is where they're going to look at that electrical impulse of that heart to get a rhythm, to see, is your rhythm regular? Is it irregular? Are you representing any bradycardia or tachycardia? Do you have any preliminary ventricular beats? Anything like that. So they'll do that as part of a diagnostic test to see if we need to go in and do further cardiac testing. Another test that they do that's not up here is a stress test for cardiac, where they put you on a treadmill and they gradually increase your ability to run and walk on the treadmill. Do you think there would be any pre-op teaching for somebody having a stress test? No? Yes, yeah. Well, you want to get an accurate reading of what your heart's really doing. And the reason that this came up to mind is because this beautiful young lady back here was telling me about pre-workout and how it's helping her lose weight. What does pre-workout do to your heart? Okay? So you would want to teach your patient that they can't have any pre-workout. They can't have any, what else makes your heart beat faster? Caffeine. They can't have any caffeine. So they want to go into this test basically relaxed with a normal diet, nothing that's going to alter their rhythm. Okay. A liver biopsy. Remember, your liver is on the right under the rib cage. Is it on the left or the right side? I should know this. I should know this. Huh?
Is that on the right?
I can't remember. Anyway, right under the rib cage. Okay? So when they go in to do a liver biopsy, that can be kind of scary as well. And because the liver is responsible for so many things of filtering out of our body, it's very vascular with a lot of blood vessels, just like the kidneys are. What's one of the risk factors with a liver biopsy? Bleeding, right. You said it. You know, if you have you said basically it could rupture, right. So you could bleed out. So again, the nurse's responsibility is to help position that client for the liver biopsy. I can't remember if there was a picture or they just talked about it in here. I don't think there was a picture of the liver. But either way, we worry about you're going to be assisting with it. Same thing with an LP. An LP is a lumbar puncture. And I believe there was a picture of that one, though, if I remember correctly. Huh?
Is that like an epidural? No.
It goes in the epidural space. So it's,
Page 429, is that what it is?
okay, page 429. So yes, typically when they do a lumbar puncture, they're sticking a needle into the subarachnoid, which is also called the epidural space, and they're collecting the cerebral spinal fluid. They're looking for any abnormalities in the cerebral spinal fluid, whether that be blood or pus or anything that would indicate infection. The nurse's role in an LP is to keep that patient still. That patient needs to be in what we call the knee to chest position. Do you see that?
Sounds like an epidural.
Right, because you're going in the epidural space. So instead of putting something in, we're taking the CSF or the cerebral spinal fluid out, but they have to be in that knee to chest position. So you're going to be on the other side, on the anterior side of the patient, while the physician is on the posterior side of the patient doing the procedure. And you're going to possibly be holding that patient so their head and their neck and their knees are all curved. That's the nurse's role for that, is to try to keep them as still as possible so that we don't make a mistake. Okay. The only other thing that I wanted to review about these tests is, remember, even when we're doing an LP or a liver biopsy, cardiac cath, we might be giving some pain medication. So part of your assessment is always going to be assessing pain. And how do you assess pain?
Oh,
On what scale?
Let's go. 1 to 10.
What's that called? Wong-Baker's. Wong-Baker's faces, 1 to 10. It's just another name for it. But it is a pain scale, the faces pain scale that we typically would use. And it's also going to be determined whether or not you give a narcotic medication or a non-narcotic medication. Some common narcotics, I don't know if these are in your book or not, but, hydrocodone, oxycodone, oxycodone, morphine, Demerol is another one. Those are some of the common ones that they'll give. If it's a non-narcotic, they're probably going to give Tylenol or maybe ibuprofen. Okay? It really depends. Remember, it's also going to depend on how the drug is metabolized, which you'll talk about in pharmacology, as far as what medication you're going to pick. And then, again, remember when you're taking care of these patients, whether you're teaching them prior to a procedure or whether you're taking care of them after the procedure, that those are the two things that you're focusing on in the nursing process. You're assessing them, and you're also performing interventions. Okay? If you're stuck on a test question, always ask yourself, what is this test question asking me? Which piece of the nursing process? Is it asking me to assess? Is it asking me to teach and intervene? What's it asking me? Okay, there's also the planning phase, which would be preparation. So is it asking you to plan? Like a planning question would be, what equipment would you gather to collect a urine culture on a patient? That would be planning, because you're going to get the equipment. Now, what equipment are you going to gather, right? Okay. But and a question that's asking you to intervene, how would you teach your patient to collect that 24-hour urine?
Like both sides, use 3 wipes.
So it just depends on what the question is asking you. Is it asking you to assess, to plan, or to intervene? Okay? Okay. I'm going to stop this for a minute.